think that there's a lot of misunderstanding around what naturopathic doctors do and don't do. In your practice, have you identified gaps in women's health and menopause health?
Evidence is evidence. Whether you're looking at it, I'm looking at it, your doctor's looking at it, we have to look at the evidence and see what the options are. So we were helping people take back their quality of life. I think it's important to know that just because something is natural doesn't make it safe, and it also doesn't make it more effective.
Interesting that as a naturopathic doctor, the first thing you mentioned to me is hormones. I'm Dr. Béatrice Séguin, PhD, and you've landed on my podcast this time of the month, your trusty sidekick to the midlife roller coaster. I chat with experts digging into legit solutions for midlife hurdles, be it health or lifestyle. Ready for the ride? Dive into this time of the month. Subscribe and catch the latest episodes on our channel. Let's own this midlife magic together. Welcome back, TTOMers. Don't forget to subscribe, like, and share. It really matters if you do, because it will allow us to continue to produce awesome content for you. Today I'm really excited because we have invited a naturopathic doctor on the couch. Her name is Dolores Fernandez. Many people include naturopathic doctors in their circle of care. So today I welcome Dolores.
Thank you for having me. I'm excited to be here.
We're so glad you're here. And I think that there's a lot of misunderstanding around what naturopathic doctors do and don't do. And I always like to understand the person's why. Like why, what brought you to naturopathic practice?
What brought me into naturopathic medicine as a whole is probably different than what brought me into menopause. From a young age, I saw a naturopath, and it was just general health. We talked diet, we talked movement, we talked very little about supplements, actually. And I just felt like that was missing in medicine, probably just because of the nature of our medicine. There's no time, more than anything. And so I thought that would be a great place in medicine to be an ally to patients, to doctors who don't have the time to do that stuff. And so, yeah, that's why I joined naturopathic medicine. But then when I started working I always say menopause found me, because there was a couple pieces to it. The first being probably my mom. And so when I was in school, maybe like 6-7 years ago, my mom started her transition through menopause. And naturally she turned to me and she was like, you're doing this natural thing. I don't want drugs. I don't want hormones, but I need help. Like, I can't do this anymore. And so I looked in my textbooks, I talked to my teachers, and I was getting nowhere. And so I reached out to practicing NDs. I reached out to anybody that would talk to me, basically, and started her on supplements, and we were literally getting nowhere. And it was terrifying because I was watching what was happening. I was watching my mom change, and I was like, there has to be more. There has to be more for people who are aging, like more than you're just getting old. And so I finished school, I'm watching my mom struggle. We had talked to her family doctor, she got sent to specialists, and it was all
part of aging, live with it.
Yeah, this is natural. So then when I finished school, I decided I was gonna start looking at what I could do. And shortly after, I actually found NAMS, formerly known as NAMS, and now it's the Menopause Society. And I found a group of NDs who were practicing evidence-based medicine, and I just got in contact with them, and I started learning about how different this profession could be if we followed evidence. And so I got my NAMS certification, and slowly my practice started just being menopause because referrals were coming and we were seeing improvements. We were helping people take back their quality of life.
So tell us a bit about the Menopause Certified Practitioner process, which is provided by the Menopause Society, which is actually based in the US, but it is global. It's considered a global organization, yeah.
Yeah, I chose to do that. Part of it was because of I wanted to learn more about hormone therapy, and we had access to prescribe it, and I didn't feel I could. I wanted to really take more training. So that was part of why I did it, but also to have an acknowledgement in somebody who knows a little bit more about menopause. And it just kind of fit my practice being an evidence-based practice. So I decided to write the exam, sign up and become a member. And yeah, that's been a really great add-on for me.
I'm not sure everyone knows that naturopathic doctors in Ontario, we are in Ontario, have prescribing privileges. So tell us more about that.
Yeah, our scope is quite small.
Okay.
I wish it was larger because we could do better work. But yeah, we have access to pretty much just some hormones. Some supplements are considered drugs when they're in higher doses, so we have access to those. If you've done the exams, you may have access to IV. There's additional exams, so everybody that finishes school is not just given the privilege to prescribe. There's additional a prescribing exam that needs to be done through pharmacists. It's not a large scope, but we do have some access to stuff.
And interesting that as a naturopathic doctor, the first thing you mentioned to me is hormones. Hormones and hormone therapy for menopause, perimenopause, is so controversial still. So I really am interested in your take on it, because I would have expected you to bring up perhaps a supplement instead. So
yeah. I think that it's important in healthcare that we all kind of follow the same guidelines in a way. And so the only way we can do that is if we follow evidence, because evidence is evidence. Whether you're looking at it, I'm looking at it, your doctor's looking at it. And so we have to look at the evidence and see what the options are. And in the hormone world, HRT, MHT is the gold standard for certain things, especially hot flashes. Now we're talking about bone health too. And so depending on the person, because I'm sure you know, not everybody's a candidate for it, if that's an option and that's the best option, why wouldn't I offer it to my patients, right? And so that is the gold standard, and we have options for people who don't want it or are not candidates for it. And so really my practice is rooted in just helping my patients feel better with what we know, not what we can guess and not what we assume, but what we know.
And that's why when I met you, we had coffee. We were introduced by a mutual friend. And I feel like we're in such a divide. Things are always either or, and it doesn't leave a lot of room for debate and nuance. So what would you want to say with respect to your specific practice and how you use evidence to guide you in treating women going through perimenopause?
The beauty of my practice is that the way I treat everybody is different depending on their needs. And so I have some patients who I am the prescriber for their hormones. I have other patients who their doctors are prescribing it, and we're doing other things. We're working on diet, we're working on sleep, working on stress management. And so the beauty of my practice is that depending on the person in front of me is how I'm showing up and how they need me. It's important that everybody knows their role in healthcare, I think. And that goes always. Like, you don't want to show up to your naturopath and say, my doctor said no to your treatment, and you don't want it the other way either. Like, if we're all using evidence, then we should all have similar ideas as far as how the treatment should go.
How do you work with what we would call traditional practitioners, traditional medical doctors?
Yeah, I work very well with them. And so normally it depends on what I'm doing with the patient, but especially if I'm doing menopause hormone therapy, I will always send a letter to introduce myself. I will send them a reasoning why I've started what I've started, send them any blood work I have had done, and just kind of keep them in the loop, because hormones, yes, now there's a big movement that hormones are safe, but your GP needs to know what you're on too. I'm not going to work in silo. I don't think that works for anybody. So I try to introduce myself and just say, like, this is what we're doing. Do you have any questions? And I have great feedback. I actually have a lot of the MDs in my area referring to me because they're not comfortable prescribing hormone therapy. So we have this great relationship where we just work together.
And where would you say your practice can differ in terms of how you approach a patient?
From like conventional medicine?
Yes.
Or from, honestly, the biggest difference is that we have time, I would say. Like, I have an hour and a half with the patient the first time I meet them. And going forward, they get to choose how long they want to spend. So if they want to talk about hormone therapy, risk-benefit analysis, they might book an hour and we will spend 1 hour talking about your risks and benefits taking MHT. The biggest difference is that beauty, that I get to spend the time and I get to spend a little bit more time and emphasis on the lifestyle aspect because the research is quite good in that department.
The lifestyle aspect is huge, and I get a lot of questions and I see it online, the confusion around supplements. And I think today I want to spend time on that with you because we've had a few episodes where we've gone deep on benefits and risks of menopause hormone therapy. So let's talk supplements. Yeah.
What are you wondering?
Well, I think a lot of people don't know which ones have evidence and which ones do not. And I think the goal here is to provide our viewer with as much information as possible so that they can make an informed choice about their own health. So maybe talk about 2 or 3 supplements that you know there's evidence for and what they would be good for. Yeah.
I think I just would like to start off with saying that it's a little bit challenging because there's not data on everything, right? And that's not to say that just because there's no data that it isn't useful for certain things if the data's not there, right? So that's a big challenge that the profession faces, is that we want to stay evidence-based, but there just might be no data. But that is probably where working with somebody would be ideal, because it's hard for the average person to know how to sift through research and understand what they're reading instead of just reading blogs or social media. I would say the 2 top ones that come to mind that I get asked about a lot is vitamin D. So a lot of research on vitamin D, and in a lot of pieces of medicine does that show up. And so I'll usually tell people, we're going to blood levels. We're gonna run the blood work, we're gonna see where you're starting, and then we'll try to get you to the optimal levels depending on where you start. And I would say another one would be ashwagandha.
Okay.
There is some good meta-analysis and systematic reviews on ashwagandha, and I don't want to blanket prescribe, but some of the research is in anxiety and stress management.
Yeah, it's from what I understand, the evidence is more for anxiety or cortisol as opposed to hot flashes, because some people have referred to it for hot flashes, but the evidence there is not as much.
No. I feel like, it's hard. I don't blanket prescribe. I never, every person that walks in leaves with a different plan depending on them. But a big priority for me is also iron. And that's another one we're working to blood level. So we're looking at, what does the blood work say? Do you need an iron supplement? So that's another one that has a lot of evidence.
When a patient comes to you, do they sometimes suggest a supplement, and which ones would you say, guys, the evidence just isn't there for it, you're wasting your money, for example?
Oh yeah, lots.
Okay, give
lots.
us some.
So I would probably start with probiotics. This blanket overall health probiotic, and I know people aren't gonna wanna hear that, but there really is no good research for people to take a probiotic just because. There is evidence in certain things, but to take it just for general health is not something I typically recommend. I would also say it about a multivitamin. Everybody does not need to be on a multivitamin.
Right.
There are certain populations that will benefit from one, but not everybody needs to be on one.
Can we get most of our vitamins from whole foods?
Yes.
Yes.
Yeah, I hope so. And then we talk about diet, right?
Yeah.
And then if the diet's not great, maybe not. But most of the time, if you're booked in with an ND, you're ready to make some dietary changes.
Yeah.
And so I try to keep people off supplements as much as I can because I don't personally love taking them. So only the necessary ones that we're seeing impact do I usually recommend.
That's a helpful North Star, I suppose, is try to get everything you can from whole foods, from everyday. No, you don't have to pay like that. I guess that's my concern, is the supplement industry is tied to a lot of revenue.
Yeah, it is. And there's some that are great. I'm not going to say they're all a money thing, and I've definitely seen supplements make big impact on people, things like chronic urinary tract infections. I do see changes when we use supplements.
Like which ones?
Like cranberry.
Yep.
For prevention, not for treatment.
Yeah, for prevention.
That's a big one.
Keyword, yeah.
Yes, not for treatment. Once you have one, you need antibiotics. Things like that. And so if somebody's getting a UTI every month and then we start giving them preventative antibiotics, there is research for cranberry, so why wouldn't we try it first, right? Like I do think there's a place for supplements. I think we need to be selective, and that's where this individualized approach is necessary, which means I need to sit with you and I need to take the time to learn about your health. So I would say that the natural supplements are definitely not going through the same processes that Health Canada drugs are going through, or FDA approvals. They're trying to make it better. They want to put in place more regulation behind it, but it is important to know that there are companies that are trying to do more. There are companies who are providing third-party testing and proving that what they say is in their supplements are in their supplements. And so I think for the consumer, it's important to know that if you work with an ND or anyone who's reputable, they're choosing supplements that have third-party testing to try to provide that. I think it's important to know that just because something is natural doesn't make it safe. And it also doesn't make it more effective. And there doesn't necessarily always need to be a preference for natural. I like the example of coconut oil. People love to use coconut oil as a vaginal moisturizer, and coconut oil is a little bit of a natural antibacterial / antifungal. And we want to keep the vaginal microbiome pretty balanced. And if we're putting in an antibacterial, that might actually mess things up more and have the wrong pH. And so in that case, I would say natural is not better.
It's a great example. I've heard of other things being proposed for vaginal dryness.
Yes, like Crisco.
Like Crisco.
Yeah, and being told that it's natural, so it's better.
Yeah. So what would you recommend to your patients suffering from vaginal dryness?
Yeah, the only good research we have that's non-hormonal for vaginal dryness is hyaluronic acid and vitamin E to be used as a moisturizer. And then you can always use a lubricant as needed to reduce friction.
What are the top complaints that you hear in your practice with women going through perimenopause?
Like as far as supplements or just their
symptoms?
Symptoms. Symptoms are just everything. There's hot flashes, poor sleep, anxiety, mood changes, weight gain, vaginal dryness, joint pain, aches.
And how do you approach each of those symptoms?
Yeah, and so I'll usually start with like, what are your priorities? Like what is affecting your quality of life the most? And can we make an impact short term? So I'll usually have my short-term goals and my longer-term goals. And sometimes those long-term goals are more things that I care about and the patient doesn't necessarily care, like bone health, for example. Bones are not sexy. Nobody wants to talk about it, but I know it's important as people transition through midlife that we're talking about it. So things like sleep, for example. If you're not sleeping well, of course you're going to have brain fog. Of course you're going to be moody. You're not going to be able to stick to following a lifestyle plan I've given you. So for me, sleep is often a priority. So I'll kind of work with the person and see where their biggest concerns are and try to work like that.
Now, we've talked a little bit about supplements and the ones that have evidence. Are there any tests that you'd like to educate our audience on in terms of, maybe some tests are good to do or maybe not as effective as they think?
So I like to use the example of the Dutch test. And it's not that it's not effective. In my opinion, it's a little bit unnecessary.
Okay, explain.
So it's a dried urine hormone test, and they're looking at metabolites that come from the hormones and they come out in the urine. And they basically tell us mostly what blood can tell us and for a fraction of the price. And there's actually pieces to the test that it can't test the brain hormones. It can only test the ovarian metabolites. And so I can just run that in blood. And so it's not that it's wrong. The test is not wrong. It's, in my opinion, just unnecessary.
And if we tie it back to quote unquote diagnosing perimenopause and menopause, is any test even necessary?
No.
So how do we determine that we're in perimenopause?
Yeah, it's by symptom.
Yeah, it's a clinical diagnosis. And we've talked about this a lot with other guests, but it's good for you to reinforce that. Yeah. Any other tests that you want to talk about or misconceptions?
Yeah, let's talk about estrogen dominance because that one comes up a lot in my practice.
I see that on social media a lot.
Yeah, and so it's, I want I want to share that these things have good intentions, right? Like people want to help when they're making these terms up. But estrogen dominance is basically, it's not a diagnosis, which a lot of people are calling it a diagnosis. It is not. It's a moment in time. And so as you probably know, in perimenopause, there comes a point where you are no longer ovulating, and so you are not making progesterone. And so you end up having a lot of estrogen with no progesterone, which would mean it is an estrogen dominance in that moment.
Yeah.
It's all relative, right? Because hormones are
It's
always
a moment
there.
in time.
Yeah. And so it shouldn't be a diagnosis. It should be a acknowledgement, and then what are we going to do about it with this moment of time, right? But to call it a diagnosis and say, like, that's why you're feeling the way you're feeling, like, they're not wrong, but it's not a diagnosis. It's just part of the hormonal transition.
Another one I see a lot on social media is adrenal fatigue.
Yeah, like adrenal fatigue, like your adrenals are not fatiguing, but maybe it was just a nice way of saying burnout. Like your adrenals, if we were to actually test the adrenal hormones, there's no change.
What are adrenal hormones for our audience?
Probably the biggest one they're thinking about is cortisol, but it also makes a lot of salts. Your adrenals make a lot of salts that help control blood pressure and your sex hormones. So the adrenals are doing a lot of things, but everybody focuses on cortisol.
Yeah. So what would be a better way to frame that?
I would sit with the person and think about burnout, probably. And when I look back at the people that were using the term adrenal fatigue, it just seems that's what they were treating was burnout, which is a real diagnosis. So we're trying not to use that language anymore.
And what are the top things that we can do? Are they mostly lifestyle based? Give our audience some tips on how to deal with burnout.
Yeah, it depends where the person is along that path. I usually start with lifestyle things like meditation, mindfulness, diet, because that's something that tends to go on the back burner, and movement. That's probably where I would start, not supplements.
Thanks. Now, in your practice, you've identified gaps in women's health, particularly pertaining to support through perimenopause and menopause.
I have, and there's quite a few. But one of the big ones on the product side was in the vaginal world, vaginal moisturizers, vulva moisturizers, personal lubricants. There needs to be a lot of education on it because we actually have good quality evidence. And so I decided to produce or formulate my own product because of that, because there was a really big gap. And the market is changing, that's for sure. But you really need to be careful because not all products on the market are research-based and great.
Yeah, I think it's worth sharing with the audience, like in terms of many lubricants on the market, what is it about them that you think is not formulated for women?
Yeah, and so a big one is the pH, and that's something that's important, even more important as women transition through menopause, because we know the pH is already going to change on its own. So we really want to maintain a healthy pH. And then there's just so many that have common irritants. The skin in the vulva and vagina are different as we age. And so things that didn't irritate you when you were 20 might irritate you later. And so just trying to pick products that have less irritants following an optimal pH.
And I'm so thankful that whatever taboos existed are slowly, they are changing. They are falling by the wayside, but we're thankful for women like you who are identifying gaps and trying to fill the space with products that are actually good for you, for women. Any other gaps that you want to mention that you've identified in your practice?
Just the bone gap. I bring it up a lot because nobody's talking about it. Osteoporosis is huge. We know the quality of life changes if somebody has a fall and a fracture. So I'm trying to also bring light to that, and more through educating than anything.
What's the opportunity there? What do we need to do for bone health?
Exercise, weight-bearing exercise. If you're not eating enough calcium, we can talk about supplementation, but I prefer people eat their calcium, and really staying on top of the screening exams.
What age, I forget what age screening exams start?
65.
65 seems late.
Yeah, there's some exceptions, but yeah, it is quite late. There's options for people to do private and pay, but so we're just trying to prioritize bone health even without the exam, if we have to.
So we're sitting across the couch. I'm postmenopausal. You're presumably premenopausal.
Yes.
So what would you want? If you could tell younger Beatrice or your peers, like why should they care? And what's the 2 things they want to remember from you?
I think the number one would be that no matter like the resistance you're getting, if people are telling you, just live with it, and no matter what it is in health, it happens to have a big push in menopause, but that if you don't feel good, there are people that want to help you, and there's people that can help you, and that's what they do. And so don't just take that and go. That would be one. And the other one would probably be to the public, would be watch what you read online and be careful with social media. I think that social media is a great thing, and there's so many opportunities because of it, but it's also dangerous just because anybody can share anything.
At the end of the day, consult with your primary care providers who are evidence-based. Dolores, we like to end our interview with this question. What makes you feel beautiful?
What makes me feel beautiful is when I'm looking in the mirror and not noticing my physical self, and I'm just proud of myself.
There is so much conjecture and controversy around estrogen, something that your body makes. Estrogen Matters, written by Avram Blooming, an oncologist. Okay, so he has spent his life treating women with cancer. And Carol Tavris, a PhD women's advocate. They wrote this book together. It's actually from 2018, but really, you guys should all read it. It basically tackles the controversy. And what I love is that it really explains to us how misinterpreted and misrepresented the Women's Health Initiative study was back in 2002. And really, women have been done a great disservice for the last 20 years because of that study. So if you're looking for the opposite of TikTok and Instagram, little sound bites on is estrogen going to cause cancer or not, why don't you take a minute and read this amazing book? It explains it all in very plain language.